Usually any tumor will spread locally, meaning it starts in the organ that we're talking about. In this case, it would be the ovary. And what happens is it usually spreads locally. So it would start from the ovary, it can go to the fallopian tube, it can go to the pelvis, then it goes into intra-abdominal, and then from intra-abdominal it would spread to a distant place. So when we talk about ovarian cancer, what we're looking at and what we think about most of the time is what's called the epithelial tumor. That's the kind of cancer that Gildner Radner had. And that ovarian cancer usually happens in women after the age of 45. It is relatively rare to see a tumor of epithelial origin prior to the age of 45.
I see.
Okay. When you look at what's called a germ cell tumor, these tumors generally occur in women under the age of 30 or 35, and they rarely occur after the age of 35.
Do we know what causes germ cell?
Actually, it's still an abnormal growth, and it's not on the epithelial lining, but within the egg portion and the organisms that make the eggs.
And this is why it happens in young women, because
Correct.
they're ovulating.
They're ovulating, it's more reproductively active.
Now, the sex cord stromal tumors, you said they're very rare.
They're very rare, and they can be seen generally, I would say, after the age of 30.
And as you said, they're very rare. They make up less than 5% of the cases.
Well, one of the things that cause a cancer is chronic inflammation. So if you have a chronic state of repair, which happens every month, this ovary undergoes an ovulation, it is repairing, and that defect where the follicle was has to be repaired. You see an invagination of some of these cells into these coating cells into the ovary, and the ovary repairs itself. So it's a chronic state of inflammation, and that's associated with an increased risk of cancers. So if you have a lady who has menopause at an earlier age, menarche at an earlier age or menopause at a later age, then they have ovulated longer and therefore have more cycles of damage to that ovarian surface.
Oh,
okay.
So this is why it says early menstrual cycles. Let's say a young woman starts her menstrual cycle when she's 11 years old.
Okay.
And she doesn't have menopause. She doesn't go through menopause until she's 55.
Okay.
Then she would have had all these years, 44 years, of having gone through
ovulations.
But if she started her menstrual cycle at 15 and went through menopause at 50, then she has actually had 8 less years than the first woman.
That's correct.
And she's less likely to, or she has less of a chance of having this problem with her ovaries.
That's correct. Now, the other factor that will play into that is pregnancies or the use of birth control pills. So, unless you surgically are capable of removing that stem cell, you may not be able to eradicate the cancer completely. And therefore, that cell may lay dormant for a period of time, and sometime in the future could come back. It could come back as a metastatic growth, or like in a breast cancer, it's possible that you could eradicate the cell if you did not do a complete mastectomy and possibly have that area also come back. So that's why in an ovarian cancer, and we have an ovarian cancer patient, we would remove the primary organ, meaning the ovary, because we believe if you don't do that, you have a much higher risk of having this tumor come back.
In trying to diagnose someone with ovarian cancer, you say you do a pelvic exam.
That's correct.
You do a pelvic exam to see if the pelvic is mobile. What does that mean?
What you're going to do on a pelvic exam is palpate the pelvic floor, the uterus. You can see if the rectum or the bladder is adherent to the ovaries and feel how large the ovaries are, or see where the ovaries are fixed to.
Okay, and then you do an ultrasound with a Doppler flow?
When you have a tumor that's in the ovary, that tumor as a malignancy has a high blood flow to that tumor. So by Doppler flow, you're actually looking at multiple blood feeds to the tumor itself. Versus if you have just a big ovarian cyst that is not a cancer, you will not have an increased vascular flow to that tumor cyst.
And that when you have this multiple blood flow, it's in fact feeding the tumor.
That's correct.
cyst. Okay. And CA-125 is a blood test.
Well,
What does that tell you? What does that blood test tell you?
that's a difficult blood test. In that you can have a CA-125 that is elevated in people who do not have ovarian cancer. It's elevated in people who are pregnant. It's elevated with menstrual cycles. It's elevated with diabetes. It's elevated with people with endometriosis. So anything that causes an irritation to the peritoneal lining or to the thalamic epithelium, you can have an elevation with CA-125.
We want to talk about that because you see, so many people hear about the CA-125 and they think, oh, this is a definitive test. But in fact, you use it to try and get more information, but it's not.
It's a piece of information, but not the whole picture. The problem with the CA-125 is probably 60%, 70% of patients with an early stage 1 or 2 ovarian cancer have a negative CA-125 or a normal CA-125. However, when you have a CA-125, we use a number of about 200. They're postmenopausal. You have an ovarian mass, you have ascites, which is fluid in the abdomen. Then the CA-125 is telling you, yes, this is probably malignant. It's still not 100%. But yes, it's still malignant. The CA-125 is a very good marker to allow us to predict how a patient will do on treatment for her ovarian cancer.
It helps to determine what the patient will do.
That's correct.
Okay.